at the data and trying to approach this, because myeloma is not one disease. We understand that it's biologically heterogeneous, and patients present with variable disease burdens. But we can generalize very few things about myeloma. And as I looked at more and more at the data, post autologous stem cell transplant consolidation is one of them. Because every clinical trial, and I'm going to share this data with you, they have built upon, in the transplant setting, they build upon the principles that were initially established by Bart Barloghi with the induction transplant consolidation maintenance. And our European colleagues have really done bulk of that work. And when we're seeing patients, we have to use the best available evidence to achieve the goal of care for any given patient. And many times the evidence may not be perfect, but it is going to be the best available evidence. At the end, I think the real question is going to be not whether to consolidate a patient post-transplant or not, but when to give and when not to give post-autologous stem cell transplant consolidation. So those are just my general thoughts as I go into this topic. But consolidation was originally introduced into the myeloma therapy schema by Dr. Bart Barloghi back in the 1980s through the total therapy approach with cytotoxic chemotherapies. And it was an adaptation from the leukemia therapeutic schema, specifically pediatric ALL St. Jude's protocols, because Dr. Barloghi grew up as a leukemia doctor and kind of jumped into myeloma later. Currently, it's thought of as a short course of 2 to 4 cycles of chemotherapy that's given after autologous stem cell transplant and before maintenance. And the objective is to deepen response before patients go into maintenance phase. And the examples are CyBorD, RVD, or KRd as maintenance. I'm going to try to see if I can go through each of these pieces of data. So one of the projects that I initially started when I was junior faculty in Arkansas, eventually got published a couple of years ago under the auspices of the International Myeloma Working Group, was this big collection of patients who had at least 10 years of survival data, over 7,000 patients, with an age limit of 75 years. These were all transplant patients treated on transplant clinical trials, with over 90% of the patients in this data set being in the pre-novel therapy era. And one of the things that we learned from this experience was, for patients who are achieving a complete response within their first year of diagnosis, their median overall survival is much better than those who are not achieving a complete response, almost by 3 years. So one of the key takeaways from this paper for me personally was what we do for our patients during that first year of diagnosis is very important. And trying to get them to a good depth of response is very important because it will impact their overall survival. And if you start looking at the reasons why CR makes sense, it's really MRD negativity that makes CR look good. It's MRD negativity, whether you use it by flow cytometry, whether you use it by next generation sequencing, doesn't matter which mechanism you look at, the MRD negativity appears to be a surrogate for overall survival. And Dr. Nikhil Munshi had published this meta-analysis back in 2017 to that effect. So, as we build this, as I build my argument, I would argue that if the goal is to improve survival outcomes in patients, and if you're looking for best depth of response, the way that this induction transplant consolidation maintenance platform is built, it helps you get there. And we have to learn from the lessons that, from various clinical trials in trying to achieve that goal. So with that in mind, I'm going to share the EMN02 trial data. So this was a phenomenal effort by the European Myeloma Network. This was a large trial where 1,500 patients were enrolled. And I'm sharing these. I'm not sure whether it's projecting well or not, but the figures on the left are progression-free and overall survival after the first randomization, which was between autologous stem cell transplant versus VMP. And the figures on the right are progression-free survival on the right upper top and overall survival in the right lower bottom. And that's for the second randomization that was for no consolidation versus VRD consolidation. And this was after the interventions on the left. And the median follow-up time periods are listed below, about 5 years for the first randomization and about 3.5 years for the second randomization. Now, in the context of myeloma survival being about 10 years at this point in time, you have to keep that median follow-up in mind. Nevertheless, what the first randomization had demonstrated in this trial is superiority of high-dose melphalan usage compared to VMP. And the second randomization is clearly showing the benefit of VRD consolidation in terms of PFS benefit. Vincent and others may say that there is no overall survival benefit seen at this point in time, but I would point out that the median follow-up is short. And the overall survival benefit that we start seeing in the frontline setting now in 2020 is probably going to emerge after at least 6 or 7 years of follow-up. And we're going to see that in several clinical trials. And here's a good example of how our French colleagues have actually built on that induction, transplant, consolidation, maintenance schema with the IFM 2009 study, where the randomization was between carrying on with VRD for 8 cycles, and collecting stem cells, or going ahead with an autologous stem cell transplant after 3 cycles of induction, follow that with 2 cycles of VRD consolidation followed by maintenance, demonstrating better MRD negativity with the approach on the right. In terms of PFS benefit, autologous stem cell transplant followed by consolidation with VRD was superior. And again, the original report was an overall survival at 4 years. But I would not be surprised if we truly believe that MRD negativity predicts for PFS and overall survival, that with subsequent follow-up, we will start seeing overall survival benefit with this kind of an approach. And our French colleagues have gone on to kind of build on that platform. We all know about the CASSIOPEIA study design. As you can see, this is the modern total therapy design: induction, transplant, consolidation, maintenance, the same Barloghi approach. And here, what they're trying to do, our European colleagues are trying to do, is build on that platform in improving the depth of response in that first year of diagnosis by adding a monoclonal antibody. In this case, this is daratumumab. It is an anti-CD38 monoclonal antibody. And they're building on the lessons learned, building on that platform, demonstrating to us that there is already median PFS benefit on the daratumumab arm with that kind of an approach. And Philippe was pointing towards this overall survival trend. Many of us feel that it's immature because we do not have enough follow-up. But the message is the same. You're kind of building on that platform and including consolidation for patients. And then, our group, Pete Voorhees led the GRIFFIN trial, which incorporated the same principles of induction, transplant, consolidation, and maintenance. This was a randomized phase 2 study that incorporated daratumumab into the schema of treatment. And the objective of this particular clinical trial was to build on and inform the phase 3 randomization in both transplant eligible and non-eligible settings. So post-consolidation, stringent CR rates were the primary endpoint, and they were met for this particular study, demonstrating, again, if you build on that platform of VRD induction, transplant, consolidation, and maintenance, you deepen responses for patients. MRD negativity rates were also higher. This paper was published, and the follow-up is short, but I'm really interested in looking at the MRD negativity and its relationship to both PFS as well as overall survival. I do not have that data to share with you yet. I want to also highlight this particular study that was just published. This is a phase 2 study looking at, again, a model total therapy schema of KRd induction, followed by transplant, followed by consolidation with KRd, and then maintenance. The reason why I'm sharing this particular paper is many of us, when Todd Zimmerman originally presented these data in 2016 and 17, were impressed with the median PFS and overall survival being observed for this high-risk subgroup of patients. And it appears that the overall survival continues to be impressive for this group of patients. And then even PFS for high-risk patients with this kind of an approach at the 60-month mark was 57%. So, the reason why I shared these data is, even though we're thinking about, the scheme of induction, transplant, consolidation, and maintenance for all myeloma patients, perhaps the patients who benefit the most may be high-risk patients with that kind of an approach, because we have not seen these kind of PFS or overall survival numbers with any other approach so far. Another interesting study that I want to share with you from our European colleagues, and kind of build that rhetoric that high-risk patients probably benefit from this kind of approach where no other strategy has really helped, is the FORTE Trial. So the FORTE Trial was presented by my colleague Francesca Kay. This was a randomized phase 3 study looking at, randomized phase 2 study looking at 3 arms: carfilzomib, cyclophosphamide, dexamethasone, KRd or carfilzomib, lenalidomide, dexamethasone as part of induction, and then patients went on to receive autologous stem cell transplants, followed by respective regimens as consolidation for 4 additional cycles. Or patients did not receive autologous stem cell transplant at all and went on to get 12 cycles of KRd. And then the second randomization was between getting R as maintenance or KR as maintenance. And, there were several lessons that we learned from this experience. Sorry, I'm having some technical difficulties. Okay. So I was very impressed with these particular data. So what Francesca actually showed, using MRD negativity and its persistence, looking at the KRd population with or without autologous stem cell transplant, so looking at KRd, transplant, and consolidation strategy, there was better persistence of MRD negativity in that patient population compared to just carrying on with KRd for 12 cycles. So the one lesson was transplant is important. Having high-dose melphalan in the schema is important. The next important lesson from this experience was this persistence is primarily being driven by the high-risk subgroup. So looking at the revised ISS2 and 3 group, this was probably the most impressive piece of it. So, as we start to, coalesce, okay, which group actually benefits the most from this consolidation kind of an approach, I'm thinking it's probably going to be the high-risk patient group. And looking at early relapses, we see the same principle. One of the things that we recognize about being functional high risk is patients may not have truly high-risk cytogenetics at the time of diagnosis, but manifest them with an early relapse. And we all see these kind of patients. So what we see is that the proportion of patients who actually have early relapses is lower with the KRd transplant consolidation kind of an approach. So again, building the case for utilizing consolidation in patients, perhaps high risk is going to be the group that benefits the most. So, bottom line, what I've tried to demonstrate here is that MRD negative CRs are probably going to be the goal that we aspire for, and we use as a surrogate for our newly diagnosed patients to give them the best chance of having the best PFS as well as overall survival benefit. What we do for our newly diagnosed patients during their first year of diagnosis is very important. And the real question is going to be when to give and when not to give autologous stem cell or post-autologous stem cell transplant consolidation. And I would argue that high-risk patients benefit from it the most. Probably standard risk patients with residual disease post-autologous stem cell transplant would be the second category. And what we're doing within our group is this specific single-arm phase 2 study to help establish some of the guiding posts with MRD as a goal. So, In this ongoing study, all our patients get KRd along with daratumumab for 8 cycles of treatment. If they are MRD negative after induction, they either go on to len maintenance or no further therapy. For patients who are transplant eligible and they're MRD positive, they go on to receive their transplant, followed by MRD negativity test and MRD testing. And the algorithm kind of follows the same goal. The goal is MRD negativity. And eventually, I think this is what we will all aspire for, is sustained MRD negativity. All right, having said that, I think this is my last slide. I truly appreciate everyone's patience, and I'll hand things over to Dr. Ayman.
Ayman, are you mute?
Sorry, I was mute. I could not unmute myself. Something has happened. Thank you very much, Dr. Usmani, for this elegant presentation. And we'll leave the questions to the end. And would like to ask Professor Rajkumar to give his talk for now. Professor Kumar, the screen is yours.
Okay, thank you very much. And I'm going to wait for my presentation here. Thank you. That was a very, very good talk by my colleague, Dr. Usmani. And I think he is already conceding that I won, because he says you don't really need to give consolidation for people with standard risk myeloma who is doing well, only if they have residual disease, and only for high risk. And he said that many times. So I think you must keep that in mind. I will start. I have no conflicts to disclose. I will start with a couple of slides to show you where we are for the newly diagnosed myeloma algorithm, and I'll go into consolidation in depth. So clearly in the new era with so many new drugs, the question is, do we even need transplant? And I think all of us agree that transplant is still important. And this IFM trial shows that if you did VRD alone compared to VRD plus transplant, you do get an improvement in progression-free survival. And remember that the VRD alone arm also got transplant at relapse. That was the randomization. It was early versus delayed. So even though the overall survival is similar, you have to look at that as long as you do early or delayed transplant, the survival is the same. It doesn't ask the question, if you did not do the transplant at all, what would happen? So we really know that transplant still plays a role, and we are using that for most of our patients. We also know from many trials that once you finish the transplant, that if you did lenalidomide maintenance, there is a significant improvement in progression-free survival, and there's also a significant improvement in overall survival. So we have data on the value of transplant, and we have data on the value of maintenance for sure. We also know that standard risk patients get a lot of this benefit. In high risk patients, we may need extra help. And data from the HOME-ON study shows that if you did bortezomib maintenance in the high-risk patients, they can do almost as well as the standard risk patients, but patients with high risk who got only thalidomide maintenance did not do as well. So really, the current algorithm that we use at Mayo builds on these trials. For newly diagnosed patients who are standard risk, we give VRD for 3 to 4 cycles. We proceed to an early transplant, and then we give lenalidomide maintenance. Based on the IFM trial, if standard risk patients really want to delay their transplant, we allow them to do that, but we give them additional cycles of VRD and then lenalidomide maintenance, provided we are able to collect and freeze the stem cells and do the transplant at relapse. For high-risk patients, we either do VRD or add dara to VRD based on the GRIFFIN trial, and do early transplant, followed by bortezomib plus lenalidomide maintenance, and this builds on the HOVON experience that bortezomib may be necessary for high-risk patients. In high-risk patients, we don't have data that giving 4 drugs is going to be beneficial, but this is a small subset of myeloma patients in whom we feel it's okay to take a risk on treatments that are unproven. But you'll see here, I don't have consolidation anywhere in this algorithm. There's no consolidation post-transplant here. There's no consolidation post-transplant here either. And really, the fundamental thing to keep in mind is it's a good hypothesis Dr. Barloghi had, that you should give consolidation like you do in acute leukemia. But that's still a hypothesis. Myeloma is not acute leukemia. Myeloma is a very different disease. And if your real fundamental question is, does giving consolidation over and above maintenance and over and above transplant and over and above induction helps? You really have to have trials where you can isolate the effect of consolidation. You have to have trials where you gave consolidation to one group and you did not give consolidation to the other group, and they all had the same maintenance, so that you can make some sense of whether consolidation is actually adding anything. You cannot have trials where consolidation is used in both arms, because then you cannot tell whether it's the consolidation that's making a difference or whether it's changes in maintenance. So for example, in CASSIOPEIA trial, they had consolidation in both arms with VTD for one arm and dara VTD for the other, but there was no maintenance in the VTD arm at all. And so the effect is really daratumumab extra rather than any particular effect of consolidation. And the same goes for the GRIFFIN trial and so on. There are only 2 trials in myeloma which have actually randomized patients where consolidation was used for one arm and not for the other. And Dr. Usmani didn't mention this trial. This is a US trial called the BMT-CTN 0702, the stamina trial, beautifully designed. One arm was transplant, second transplant, lenalidomide maintenance. Another arm was transplant, followed by VRD consolidation, followed by lenalidomide maintenance. And the third arm was transplant, followed by lenalidomide maintenance. If you look at these bottom 2 arms, that's really where you're asking the question, I'm going to give patients transplant and len maintenance, and I'm going to give another group of patients transplant followed by VRD consolidation, and then the same lenalidomide maintenance. And let's see whether VRD adds anything. Well, the results of this trial were published, and they were published a couple of years ago, I think, in JCO. There were 758 patients randomized. And what the trial found was, if you look at VGPR or better, tandem transplant with len maintenance, 79, about 80%. Add consolidation, you're getting 82%, and single transplant plus lenalidomide maintenance, 76%. None of these comparisons were statistically significant. But more importantly, when they looked at progression-free survival, there was no difference in progression-free survival of significance between a transplant followed by len maintenance or transplant followed by another transplant or transplant followed by consolidation. All were the same. And it was the same for overall survival as well. So therefore, yes, there's a hypothesis. If you add consolidation, you'll get deepening responses or whatever, but that doesn't translate into either progression-free or overall survival in the stamina trial. There was a meta-analysis of post-transplant consolidation that was published in the European Journal of Hematology. They looked at 8 phase 3 trials and 6 phase 2 trials with specifically used consolidation therapy with about 1,000 patients in each arm. Now, this is not randomized trial, but this is a meta-analysis of various studies. They found that if you look at trials which use consolidation versus no consolidation, VGPR or better was indeed higher with consolidation, but there was no difference in CR rate. There was no difference in progression-free survival in the studies that use consolidation versus the ones that didn't, and no difference in overall survival. The type of consolidation used was lenalidomide in 2 studies, len plus prednisolone in 4 studies, in 1 study, KRd in 1 study, RVD for 2 cycles in 2 studies, and RVD for 4 cycles in 1 study. They didn't find any difference when you looked at the type of consolidation. They did make the comment that only the stamina trial was the effect of consolidation isolated. All the other trials, it's very hashmash, it's like impossible to make out anything. What they found here, you can see, when you look at progression-free survival, here are all the studies which did not use consolidation. The ones that did use consolidation, all of them have the same type of improvement in progression-free survival compared to the baseline. Same thing with overall survival. There's really no difference between the trials that use consolidation or the trials that did not use consolidation. Now, there's one trial that Dr. Usmani mentioned and that I am going to analyze in detail. That is the EMN02. This is really the outlier. This trial used RVD for 2 cycles as consolidation, and it was a clean study. It's very much like the stamina trial, the only trial in myeloma where the effect of consolidation was isolated. They had a randomization of consolidation versus no consolidation, everything else being equal. And what they found was that the CR rate was indeed higher for consolidation, 55% versus 40% for no consolidation. However, and the progression-free survival, as Dr. Usmani mentioned, was indeed better. However, as of right now, there is still no improvement in overall survival. Will a survival improvement emerge? Maybe. We don't know. But should we add consolidation based on hope? Or is there actual data that shows that consolidation improves overall survival? With the stamina trial, there is data that it does not improve either progression-free or overall survival. With the EMN02 trial, we can see it does improve CR rate and progression-free survival, but it does not improve overall survival. Why is there a discrepancy between the stamina trial and the EMN02 trial? And I think the main difference is that the EMN02 used VCD or CyBO-D for induction, whereas in the US, for the stamina trial and all the other subsequent trials, we always use VRD. So really what is happening in the EMN02 trial is that you have patients who have never received RVD, ever, and they're getting 2 cycles of RVD consolidation, and they capitalize on that lenalidomide high dose, along with the synergy with the bortezomib. And so you start to get this progression-free survival benefit. On the other hand, if you're using VRD as your initial therapy, giving another 2 cycles of VRD at the end of that transplant doesn't seem to make any difference, as you can see from the stamina trial. So I think that really is the major difference. I do agree with Dr. Usmani that we need to probably think of some type of consolidation after the transplant for high-risk patients, particularly deletion 17. But I disagree that it's going to be in the form of RVD or KRd. If it is, then you really need to prove it. But it could be in the form of an extra transplant. The EMN02 trial, unlike the stamina trial, did find a benefit in both progression-free and in overall survival for the addition of the second transplant. Now, I think, again, what is happening is that if you have multiple salvage options available, as you do in the US, the second transplant doesn't seem to make much of a difference. But if you have some problems with access to all the other salvage therapies, then maybe a consolidation with a second transplant might help. And in the EMN02 trial, when they drilled down deep, they found that this overall survival benefit was primarily for high-risk patients and primarily for the deletion 17p patients. So that may be a group, if we have more data, that may be a group that you could consider a second transplant as consolidation. There are many, many myelomas, and with time, we will find that there are approaches for treating patients will vary. And I agree with Dr. Usmani that our approach is going to be different. For patients with double hit, triple hit myelomas, for patients with del17p, I do think we may have to do something more than just the transplant and maintenance. And if our maintenance is going to be bortezomib plus lenalidomide anyway, that is like giving consolidation long term. We may call it maintenance, but it's really like, you're giving R plus V, maybe some DEX. And so it's really that framework. And so I do agree with that. And so if you look at my high-risk algorithm, it might be very similar to Dr. Usmani's trial, actually. He's using KRd for a long term, but we are using bortezomib plus lenalidomide long term. But it's really, we need something beyond transplant and just len maintenance. We need to consolidate, whether we call it consolidation or maintenance. And so bortezomib plus lenalidomide. But for most of all the other 75–80% of myeloma patients, I really don't think the value of consolidation is proven. And so we are just doing only lenalidomide and maintenance. And I'll close with that. And so thank you very much for your patience and listening. We'll be happy to answer questions.
Well, thank you very much, Kumar. Very elegant presentation. I'll give 2 minutes probably to Dr. Usmani if he wants to add something to as an answer for Dr. Rajkumar.
I think that the only thing I would, I'm getting an echo. Okay. So, I'd say, I think Vincent has done a fantastic job in covering the reasons why we should not be doing consolidation for all patients. And probably this was the challenge that both of us faced, as we were looking at the data on how to take our respective positions, because the field is moving in a very different direction right now. And so, I think, if you listen to what, the arguments that I tried to make and what the arguments that Vincent made, I think that the truth is going to be somewhere in between. And we both agreed on that. That's probably the high risk patient group is where we probably need to focus that consolidation effort. And it could be a CAR T cell strategy post transplant. It could be intensification with a very effective bispecific or trispecific antibody. So I think that the audience heard both sides of the story, but honestly, and I mean, for the most part, I saw that Vincent and I were kind of saying the same thing, that this is how we've been doing things. This is how we've made progress, but probably moving forward, we need to move in a different direction.
I have a question to Vincent. I mean, since, as you have mentioned, there is no really good evidence to give the consolidation for all patients, why most of the trials, even the recent trials, they are still giving these 2 cycles of consolidation in these trials?
So, I do have a problem with many of the designs of these trials. And if you look at the designs of these trials, they're flawed, because you cannot ask a question if you have different consolidations and different maintenance and come up with an answer. And therefore, if you look at a trial where one arm is getting consolidation and the other arm is also getting consolidation, it looks like you've already decided consolidation is effective, even though we haven't proven it. And so it's really important to look at what questions do we already know the answers to, and make sure that you're asking one clean question that tells you, what is the interpretation of the trial. If there are differences in induction, in maintenance, and in consolidation, when your trial is done, you don't know whether the outcome you saw is because the induction was different, whether the consolidation is different, or whether the maintenance is different. And so whether it's Alcyone or CASSIOPEIA, that's where my problem is.
Okay. So, Dr. Usmani, I mean, you're mentioning that if consolidation is going to make a difference, it's going to make a difference in the high-risk group. But would you consider consolidation in those who do not achieve a certain depth of response? For example, those who do not achieve stringent CR or at least VGPR, do we give, we probably don't know the answer, but do you think those who do not achieve CR or a stringent CR are candidates for consolidation as compared to those who who achieve stringent CR or MRD negativity, as you mentioned in your talk?
So, my approach in patients who have not, only achieved PR post-transplant in the standard risk setting has been to offer them 2 cycles of consolidation versus moving on to maintenance therapy. The only caveat to that is the translocation 11-14 patients which are kind of enriched in the CD2 molecular subgroup if you look at gene expression profiling. And that's the group, and I've shared this with Vincent in other conversations we've had. It's that CD2 molecular subgroup that is going to do very well regardless of what you throw at that patient. That's the group where they're going to respond to most therapies you give, and perhaps historically have had the best longevity over time, and that's the group that benefits the most from the total therapy approach. I'm still seeing a lot of Bart's patients from the original tendon transplants he did back in the early 90s who are following up with me after his retirement. So so there are caveats to it. The beautiful thing about being a myeloma doctor is not every patient is the same. Disease biology is different. So you really have to tailor those options for your individual patients. We do not have clear data to guide us there. So you have to have these discussions with the patient based on the best available evidence.
And
All right. Thank you. Yeah, go ahead.
If I may add, if a patient has had a transplant and they're standard risk and they still have residual disease, do we do something extra is an important question. And really the main philosophical thing is, do you just go ahead and do it out of hope? Or do you actually do a trial and prove that doing something like that helps? Because when you do something, there is a risk to that. There's extra cost, extra toxicity, could be even worse outcome. And so there is a trial, the Optimum trial that ECOG along with Dr. Usmani and everybody else has developed. This is for patients who are still MRD positive and after transplant and maintenance, and to add, whether to add an extra drug like Ninlaro. And it's the same idea though, whether you call it consolidation, it's extra therapy. Do you treat more to try and deepen the response? And I think these results are important. Otherwise, we will be starting to do things that we don't know whether we are actually helping people or not. The other problem which I think I have to comment on, is that you don't know when is the right time to say somebody is not yet in CR or not yet in MRD negative. Some of these patients after transplant and maintenance deepen their response for months later. So if you just give them a few more months, they might be MRD negative altogether. And the third point I want to make is, and when Dr. Usmani Saad was saying about Dr. Barlogi's patient, we all have to be aware of one thing. If you take, we just have a paper that's going to be published soon. If you take patients with newly diagnosed myeloma and give them 4 cycles of induction and transplant and do nothing else, just let them go, there is a subset, 10-15%, who will go years, like 8-9 years without any progression. When you say, I'm going to give maintenance for everyone, you are over-treating those people. And you're willing to over-treat because you don't know who these people are. And unless you give everybody maintenance, you won't get the benefit. So we have to recognize that every time we add something, it's going to put some patients who would have done well anyway at risk of something, whether it's heart disease with carfilzomib, or whether it's going to be neuropathy with bortezomib, something you're adding. And this is why it's so important to do the trials to prove our hypothesis.
All right, thank you very much. Before we go on to the questions, I would like to have an answer from the audience for the same survey that we started with. I guess we can start the survey again. Yes, please, for the audience, please answer yes or no based on what you heard. And let's see if you have changed your mind. Can we end the poll? Yes. So not much changed, but less people participated in the survey than previously. It seems that probably more people are confused rather than having clear answer. And that's why probably we have a debate.
Right. I think if you did the same question with, would you give consolidation post-transplant for standard risk patients, and would you give consolidation for high-risk patients, you will get much more clear answers, because both of us were saying pretty much the same thing. The standard risk, we probably just do maintenance. For the high risk, we'll do some consolidation, whatever we call it.
Okay. So we have a few questions here. Let me publish the first question. It's to Dr. Vincent Rajkumar. The studies you mentioned, they did not focus on MRD at all. So how can you judge on overall survival and event-free survival? I guess...
Yeah. So, you know, MRD or minimal residual disease is a means to an end. It's not the end in itself. Just because you get MRD negative doesn't mean you're going to live longer. You saw in the Bellini trial, they had 5 times higher MRD negative with venetoclax and twice as worse overall survival. So MRD negativity, you need to know what it represents, and what do we know and what do we not know. So we know for sure MRD negative patients live longer. So it's a good prognostic marker. But what we don't know is if you take the MRD positive patients and give them extra therapy, will they live longer or not? That requires a randomized trial. Many such trials are going on to see if you act on that MRD result, could you make a difference? And those studies need to come out before we can judge that. And thirdly, we don't know whether MRD negative does mean cure. That needs much more long-term follow-up, and whether it's a surrogate for cure or not remains to be seen. And finally, whether it's a surrogate endpoint for randomized trials. Is it a surrogate endpoint for overall survival or event-free survival? That's what the I-squared team is trying to do. And actually, we are pooled a lot of data, and it's really, we don't have that much data on overall survival and MRD negative, whether it's a surrogate endpoint. So there's a lot of unknowns, and that's why I didn't focus on the MRD. I went for the real endpoints, which is overall survival and event-free survival.
All right, the next question is actually this more or less similar to the question that I asked Dr. Usmani. So the answer is there already. There is this question that says, in Saudi Arabia, we see many young high-risk myeloma patients. After VRD induction, would you recommend a second auto followed by R maintenance, or no second transplant but VR maintenance? I would like to get the answer from both speakers. We'll start with Dr. Kumar.
Oh, it's going to be really, really awkward if I say tandem transplant and Dr. Usmani from Arkansas says no tandem transplant. You know, I have been really, really brainstorming with my colleagues. The Mayo colleagues have been brainstorming, and we are really, really, it's a hard call to make, because we have the stamina trial where the second transplant didn't add much even for the high-risk patients. And then the EMN02 trial, where there's a clear benefit for high-risk patients with overall survival. If you see, it's not in the paper. You have to go to the supplement to see the progression-free survival curves, the overall survival curves for the deletion 17 patients. It's wide. It's really wide. And so our group, I think, is going to say consider a second transplant for patients who are young and high risk after the first auto. And then after the second transplant, then we'll probably do len and bortezomib maintenance. Really going all out.
Yeah.
Okay. Dr. Usmani?
So, I would actually echo what Vincent is saying. We had a lot of discussions around this, within our group as well. And we thought that the amount of residual disease may actually dictate whether we go for that second auto in that high risk, young deletion 17p or even, patients who have two karyotypic, high risk karyotypic abnormalities.
Right.
If they've achieved good depth of response, then just move them to VR maintenance. But then, if they still have, say they're in a VGPR, then I think offering them that second auto would be a very reasonable approach.
I would agree with Dr. Usmani. I think that's probably the best strategy.
All right. Another question, just to follow up on the STAMINA trial. Did STAMINA trial show any difference for hazard ratio for high risk multiple myeloma?
Not that I know of. It was not there in the publication, and I think they had an update at ASCO. I didn't think that there was any difference in that either. Saad, do you know?
Yeah, I agree. So Hari had presented on the intent to treat patient population, there was no difference. Correct. But for as treated, they reported, which is funny way of presenting the data, that there might be a hint of some benefit for high risk, but I don't take that into account. I think you have to look at the intent to treat patient population, and there was no difference.
There's a question about post-transplant Velcade maintenance for those who cannot or who could not take lenalidomide maintenance. Do you give them just Velcade or try something else? Not high-risk patients, basically.
Oh. Well, we don't know. There aren't that many patients who cannot take lenalidomide at all. I mean, in those patients, it's hard to know what to do. We have done bortezomib maintenance. Some patients, I think, particularly the second transplant, if it's like a salvage second transplant, we've done pomalidomide maintenance, or even sometimes DARA maintenance for these patients. There's no data, so it's like I'd be curious to know what Dr. Usmani does.
No, I agree. I mean that there is, there's no data there, and you have very low number of patients who can't tolerate len. But if they're standard risk, if they're in a good response, and for some reason they started on len, couldn't tolerate it, and you've been dose reducing, I think it's reasonable to take them off and just watch them, without maintenance, instead of trying to.
If you were to give maintenance Velcade for how long? Until progression.
I guess, or tolerability issues. I think that Velcade continues to have, there are patients who are not going to have any neuropathy or any GI issues, but many patients do develop it over time. I think it's it's related to exposure as well. So yeah, you have to look into both tolerance and benefit.
Correct. The HOVON trial used it for 3 years, but again, high risk patients, we are so scared at 3 years if they're doing well to stop it. So if they are not having neuropathy or GI issues, I have continued it, maybe give them bigger breaks, but generally continue till progression. Like he said, I guess.
There is a question here. I don't know. What about maintenance if you use auto followed by RIC allo? Any maintenance post allo in patients, the very selected patients who get allo transplant, would you consider maintenance after allo, or you wouldn't?
Generally not. I have to say the last time I was having the same discussion with Dr. Loniel in another panel just last week, and we were posed a similar kind of a question. The general consensus is when you're thinking about an allo, that represents an access issue. That you either don't have access to clinical trials or other options for that given patient. Because if you look at the allogeneic stem cell transplant trial data, it's been kind of an aspirational goal. I think Vincent alluded to this for consolidation, but we've been hoping that allo will help myeloma patients. We've been hoping, doing clinical trials, comparing it with tandem transplants, auto allo approach comparisons. We really not have demonstrated good graft versus myeloma effect in a randomized clinical trial. So with that premise in mind, if you are going for that option, that there not going to be any data to guide you. So if your patient is post-allo, is having graft versus host disease effects and still has reduced residual disease, what you've achieved is a myeloma relapse along with GVH. So it's that there is no data to guide us there. And if you were to go down that path, then I wouldn't recommend maintenance. Just watch the patient.
Any additions, Vincent? Probably you are mute. Dr. Rajkumar, you are mute.
Sorry, I agree. I mean, we hardly ever do these, probably 5 or 6 a year. And those are very selected patients, unique circumstances, and each one is managed according to that circumstance. There's no general guidance we can give.
So this is probably the last question. So in patients with extramedullary disease, and we know for a fact that this group of patients really is something very difficult to treat. Would you change your strategy post-auto transplant, or would you just give maintenance for them as usual? Dr. Usmani?
So extramedullary myeloma is usually accompanied by elevated serum LDH, which we consider as a high-risk feature, and we actually would give patients a PI and IMID based maintenance in that setting. Velcade every other week along with Len would be the maintenance strategy for those patients, not just Len alone.
Yeah, I agree. I think we would treat these people like high-risk myeloma.
Well, we are approaching the end of the debate. It was very interesting. Again, thank you very much for our distinguished speakers, Dr. Usmani, Dr. Rajkumar. We were happy to have you with us in this webinar by the Saudi Society of Blood and Marrow Transplant. I would like to also thank the audience for their questions and for their patience with us. This is the next webinar next Saturday. It's something totally different than myeloma. It's about warfarin, whether it's dead as a treatment for VTE or not. So we'll see you next week on Saturday, and we will say goodbye for now. Thank you again, and goodbye.
Thank you so much. Thanks for having us. Bye, Saad.
Thank you. Take care, Vincent.
Thank you.
Thank you.